just recognizing adequate and inadequate breathing, we're looking at rate, quality, and effort. And don't ask me why there's a phone there. I don't know. It's just what popped up. But we're looking at many things. We're looking at rate. Normal rate is 12 to 20 breaths per minute, but things come into play there. Things like what they were doing when this all started to happen. We're looking at quality. Is it normal? Are they having to work for it? Do we hear wheezing? Is it equal? Going to effort once again. Do we see nasal flaring? Are they barrel chested breathing? Do we see intercostal spaces and the clavicles areas sinking in as they're trying to get breaths? Are they hunched over in that tripod position? Maybe a pediatric, and they're sniffing, and their nose is up in that sniffing position. A number of things. Right, those would be inadequate versus adequate. Now, keep in mind, that rate. Someone who runs a lot, like a triathlete or an endurance athlete, their respiration rate might be lower. They might be in that 8 to 10 range. So that may not be concerning or alarming. So take those kind of things into mind when it comes to whether or not you're going to intervene or not on how they're perfusing, get an SpO2 reading on them, see how they're doing in general. Are they having a hard time talking? Is it 2 to 3 word dyspnea where they can't breathe and every other word or every couple of words they're having to take a breath or breathe, and it's obviously labored? Looking at rhythm, is it an ataxic rhythm where it's unidentifiable, there's no pattern to it? Or is it, a Shane-Stokes or a Biot's where there's a rhythm to it, but it's still not normal because it's getting faster and then it slows down and it stops, and it goes faster and it slows down and then it stops? These different things, a lot of them are common with like head traumas and whatnot. But they all come into play. Listen to lung sounds is huge as well. Do I have bilateral lung sounds on both sides where they're clear? Or am I hearing sounds of wheezing? Am I hearing, stridor? Am I hearing rails and crackles and fluid? Or, a dry rubbing sound of like pneumonia or COPD? All these things will help, steer you in directions of care. Do I have absent lung sounds? Do I have good lung sounds on the left side, but the right side is absent or diminished? All these things can tell you stuff, and the more information you get and the more you do, the better off you're going to be in the long run for treating your patient. The biggest thing here, though, is even if they're breathing fast, at 26 or 27, 28 breaths a minute, look at that quality. We may not be intervening at that point if they're still breathing okay and they're perfusing okay, and cap refill's good, they're not altered, it's not 2 to 3 word dyspnea, but when it gets to that point of they're hyperventilating and now it is 2 to 3 word dyspnea and perfusion's going down and now they're a little bit more altered, then we might want to look at intervening with that kind of stuff. When it comes to intervening, let's talk about area management a little bit. So, obviously, if they're unconscious and talking to us, there's no need for this. But we got head tilt chin lift, we got jaw thrust maneuvers. Okay, you've just got this simple opening of the airways. Okay, that's your head tilt chin lift. The first one, this is your jaw thrust, or the equivalent of it. Head tilt chin lift, so you can kind of see the airway opening in here, tongue being lifted up. Now remember that here's your jaw thrust, how much more that opens up. For your traumatic patients, we're going to try to do, this is just lifting the tongue, this is kind of cool. Doink. All that open up. Patients who are suspected of having a head trauma or neck trauma or back trauma, we want to try to maintain that jaw thrust maneuver because it's going to maintain spinal better than a head tilt chin lift. would. Okay, it's still, is going to disrupt it a little bit, but it's a little bit better. But in cases of CPR or things like that, obviously we don't care. Head tilt chin lift is easy to maintain, so that is what we would do in worst case scenario. Okay, suctioning. Many different suction devices. Sawtooth, this is what we have here. If you've never seen one or play with one, pull one out, try it. A little bit of assembly is required usually. They do work really well though once they're assembled. The only downside is this canister is really small compared to these bigger ones. So just keep that in mind when it comes to it. We'll suction adults for no more than 15 seconds. We'll suction pediatrics, like kids, for 10 seconds. And we'll suction infants for 5 seconds. You will want to know those numbers. 5, 10, 15, infants, kids, adults. But as far as suction goes, you've got the rigid suction catheters. You have soft tip catheters as well. Don't be afraid to use a soft tip on pediatrics. Suctioning noses out is great, and especially your pediatrics. I'm sure those of you that have heard Tia Dixon, the pediatric nurse from Primary Children's talk, she goes in on that in depth. It's one of her soapbox moments. Suction noses, guys. It's an easy thing to do, and it helps them a lot, especially those little kids. Remember, we want to suction for that time limit of 5, 10, 15, and then ventilate as needed. Because when we're suctioning, they're not breathing. When we suction, we can do it one of two ways. We can either measure from the corner of the mouth to the earlobe and only go down that much, or we can just go down until we don't see the tip of the catheter anymore. But just be careful on depth. We're not going down the trachea. We're not going down, just to the back of the mouth. Suction out as needed. Preferably suctioning on the way out. Larger objects, teeth, chunks, we're not going to suction. We roll them on their side, kind of scoop it out with the suction catheter, then suction the fluid, sputum, and things like that. Airway adjuncts. You got your OPAs and your NPAs, oropharyngeal airways, and nasopharyngeal airways. With these, the OPAs will measure from the corner of the mouth to the earlobe for sizing. You can do these on anybody that doesn't have a gag reflex. So unconscious patients, semi-conscious patients, that gag reflex is sometimes still intact, so they won't accept it. But it's a great way to maintain an airway, keep that tongue off that back of the throat. When we put these in, the way they go, the flange goes at the teeth, right? They go in the mouth. You can put them in upside down, so that this is going towards the hard palate, and then rotate 180 degrees as it goes in, so that it sits down. The tongue will fit right in this cavity right here, this little arch. Or you can go in sideways and rotate 90 degrees down. That's how I do on everybody, because pediatrics, you don't want to do 180 degree twists because they have a soft palate, and if I put that in there, this might damage that soft palate. So I'll put it in sideways and then rotate down so that this is going down towards the trachea, down towards the throat, so that the tongue sits in this little arch, right? NPAs measure from the corner of the nose to the earlobe. You lube up the tip a little bit, and then they just get pushed in, right? If you meet resistance, you stop. The only contraindications for an NPA would be if you meet resistance, don't push past it. Obvious facial trauma, things like that. If they've got a broken nose, they have that facial trauma going on. We don't want to try to push past that, because we're going to be pushing things in areas they don't belong, or possibly deviating one of these NPAs somewhere where it really doesn't belong. Oxygen therapy, nasal cannulas, non-breather masks. I'm sure everyone here has seen these. Nasal cannulas, 1 to 6 liters per minute. Don't go any higher than that. We put it on, put it behind the ears. This is great for just maintaining an oxygen level, right? We want to keep an oxygen level, a saturation of like 94% on the SpO2. So if they're in that like 90 to 93, 94%, they're kind of hovering, nasal cannulas are great just to kind of maintain that when we can titrate that, meaning we can adjust that as needed based on that and kind of play with it, right? Non-breather masks are great for your breathing problems, asthma patients who are really having a hard time, and several others as well, trauma patients as well, cardiac patients, people who need more oxygen in a high demand, 10 to 15 liters per minute. Fill that bag up at least 3/4 away. That's kind of the reserve, so that way if the tank runs out, they don't start just breathing in their own CO2. They have a little bit of bag left over. Once again, basing this off of the SpO2 and all that, right? We can adjust these as needed. We can switch out machines or devices. If we put this on, but they're claustrophobic and they don't like it, maybe put them on a nasal cannula. Okay, there are different options here, and for many different situations as well.